Good afternoon. I'm Mark Wallace. I'm the chief of the division of pain medicine at UC San Diego. And I've been using medical cannabis for many years. And the goal of this quick talk is to give you a little bit of my experience on dosing and the evidence behind it, which we've done a lot of research with it. So these are my disclosures. I'm a grant reviewer for Cleaver Leaves, which is a company that provides medical cannabis products free of charge for research. So first, let's talk about the scientific rationale for THC dosing and titration. So this was the very first study that I did with cannabis, and I spent years developing this intradermal capsaicin model, where I would take healthy volunteers and give them a therapeutic and sting them with capsaicin on the arm and see how the therapeutic affected it. So with this design of this study, we dosed them with cannabis. It was double-blinded, randomized crossover design. So each of the subjects was exposed to placebo, 2%, 4%, and 7% THC. Very little CBD in the leaf. And this was smoked. We exposed them. 5 minutes after exposure, we stung them on one arm. 45 minutes later, we stung them on the other arm. And this is the results. Where 5 minutes after, where they were most high, they would give highness scores of like 7 out of 10 with the high dose, 7%, maybe about 2 or 3 out of 10 with the low dose. No difference with the 3 doses. But when we went out to the 45 minutes, you can see they separated. Where the low dose had no difference from placebo, the medium dose reduced the pain, the high dose actually worsened the pain. They were reporting more pain. So then we followed this up with a study in diabetic peripheral neuropathy. Same paradigm, but they vaporized it. We put it in a big volcano vaporizer, exposed them to placebo, 2, 4, 7, and then we followed them and followed the effect on their diabetic peripheral neuropathy pain for 4 hours. And then what we saw was this dose-dependent reduction in pain, but you look at the highest dose and it looks like it's starting to turn the corner and come back up for the elicited pain scores. So then when I did this study, I ran out of money and I couldn't, we drew blood levels, but I couldn't test the blood levels. So then I subsequently got funding to look at the blood levels that we had stored and understand when you're inhaling it, the blood levels are all over the place. Sometimes there may be a subject that's getting the high dose that had a lower dose than ones that were getting the medium dose. So what we did is we pulled all of the blood levels and did a correlation analysis. And you can see this inverted U, where as the plasma level goes up, the pain level goes down. But then it starts to go back up and it loses its effect at the highest. So the therapeutic range of THC plasma level seems to be around maybe 15 to 30 nanograms per ml. That's a pretty low dose. If you look at the cutoff for like the World Anti-Doping, it's like 200 nanograms per ml. So we're showing that the efficacy is occurring at low doses. So this has been reported about the biphasic effects of THC and CBD. So THC, very narrow therapeutic window. So you go from 1 milligram to 20 milligrams and you get totally opposite effects. 1 to 2 milligrams, up to about 5, anxiolytic, analgesic, 10 milligrams paranoia, 20 milligrams psychosis. If you look at CBD, it is also biphasic. Now, there's a big hype around CBD. The doses that we're using from the dispensaries is probably not effective. Because to get the doses you need, it's cost prohibitive. So you have 15 milligrams, which is what most people are using, maybe 15, 60. It actually is alerting, it's stimulating. Then you start getting into higher doses, maybe a couple 100 milligrams, you start getting sedation. And then 400 milligrams, more sedation, and then you get this antipsychotic effect, anti-seizure effect when you're getting up in the 400 to 800 milligram. No patient's going to be using that. They'd be spending $1,000 a month to get those kind of doses. You look at Epidiolex, FDA approved to treat Dravet syndrome, retractable seizures. That's about $20,000 a year in cost for the CBD, but they're using up to 800 milligrams a dose in infants. That tells you how high of a dose you need. So there is a theory that these biphasic effects may be associated with disease states. So you've got Low doses or endocannabinoid deficiency may be associated with migraine, fibromyalgia, anxiety, whereas endocannabinoid excess may be associated with schizophrenia, substance abuse disorder, obesity. So you can see the endocannabinoid system can also get out of whack and put us into disease states. So this is the cannabis pharmacology and dosing. Inhalation is the best way to get it in. It peaks very rapidly, but it comes down very quickly. So you're only going to get maybe 2 hours out of it, as opposed to ingestion, very erratic absorption, very delayed effect, but you're going to get a longer effect over time. We recommend, if you're inhaling it, we recommend using organically grown flower with a temperature controlled. I'll go over a little bit in this in just a minute. These are just a chamber. You open up the chamber, you can put in the THC, the cannabis concentration that you want, 2%, 4%, and then they can titrate it. We do not recommend vape pens. We do not recommend inhaling any extracts. And then we have the primary benefit is from the THC. There's no human studies to support CBD as an analgesic, and the patients actually report little to no benefit. You have patients that are reporting benefit, it's probably contaminated with THC, a little bit of THC. There has been one placebo-controlled study showing no benefit of CBD in acute low back pain, and they were using pretty good doses, about 100 milligrams, 100 to 200 milligrams. And then, however, I also understand high-dose CBD can elevate liver enzymes. Now, however, having said that, we always combine CBD with our THC because it seems to reduce some of the psychoactivity even at low doses. So there's a number of oral products. The key is that you're going to choose these products based on CBD THC ratios. They all have the same pharmacokinetics. They have a very delayed Tmax. They have much longer duration of action. So a lot of patients that use the edibles at night. They may use the inhalation, the vaporization during the day. So this is a kind of a summary of how we dose it. For inhalation, use a vaporizer that's temperature controlled. Put the desired concentration in there. We always tell them to start off with the lowest concentration possible, 1% if possible with THC. They can put a little bit in there, and then they use temperature control. Start off at 175 degrees centigrade, and then they can start taking it up at 5 degrees centigrade at a time. The potency will be based on the CBD to THC ratio, which I'll show you in just a minute. Duration and number of inhalations is going to increase the amount that they get, together with the temperature control of the vaporizer. For oral delivery, the key is to start low and go slow. We always start with about 1 to 2 milligrams twice a day, and then slowly titrate up from there. We change the ratios between day and night. During the day, we usually start off with about a 20 to 30 to 1 ratio, CBD to THC. And then if they're doing oils, take about a quarter of a dropper full of oil, maybe drop it under their tongue, let it sit there for a couple of minutes, and they swallow it. Then they can kind of titrate up from there. At nighttime, we typically go to a 1-to-1 ratio. And now if you take a 1-to-1 ratio compared to a 20-to-1 ratio, taking a quarter of a drop, they're going to get about 1 milligram of THC with a 20-to-1. With the 1-to-1, they're going to get about a 4 to 5 milligram dose of THC. But we want that higher dose of THC at night. So this is how we do it at UCSD. Failure of conservative therapies. We want them to fail conservative therapies first, but should it come before opioids? I think it should, and I have a lot of patients that I use before opioids. We provide them a Department of Public Health application to give them medical access. We do a dosing consultation to actually sit down with them to go over the different ratios, the different products. And then if they're on an opioid, I make them start weaning first, and I try to get them off of the opioid. The goal is to get them off of the opioid if you're going to add cannabis. I follow up with them. Urine drug testing, I do it because I want to document that the THC is in there and that they're not intoxicated, basically, is what I'm doing it for. So summary. Self-titration, patients adapt to dosing to balance pain benefits with their side effect profile. Start low, go slow. Usually you're about a 1 milligram, start titrating from there. We increase it over about 1 to 2 weeks, very slowly. And again, the CBD to THC ratio it varies from day to night. patients tend to develop tolerance to the psychoactive effects over time. But the psychoactive at the low dose, I don't have much psychoactivity. They have a little bit of a calming effect. And then these THC-mediated side effects such as fatigue, tachycardia, dizziness are avoided if you start low and titrate slow. And then less can be more. Low dose is often more effective. A higher dose can be less effective. So thank you.